Hello and welcome back to my fireside chat series on the outcome measures. So I introduced the idea of outcome measures and a treatment plan. Oh my goodness. Um, in the previous video segment. In this particular segment, I'm going to be discussing more the parent-child relationship rating scale that I developed as an outcome measure for the pathology. And this is the one I recommend everybody start using. It's daily ratings from the targeted parents on three items on a 1 to 7 scale, from 1 and 2 being awful and 6 and 7 being wonderful. The three items are affection, which is the attachment networks, cooperation, which are emotional regulation networks, and mood and social involvement, which are the mood and arousal networks. And the I'm recommending that the targeted parent rate daily the child on these three items, and then email those three numbers, not a big description, just three numbers, to the family therapist on a daily basis. The family therapist can then put the ratings into an Excel file, and we begin to track the child's symptoms over time. This is going to be very helpful when we get into the protective separation period and the post protective separation period and relapse and stabilization and all these things. This outcome measure is going to play a large role in that. And so I recommend that people just start collecting that early on. Right now, and it's anticipated most of the ratings for active child abuse would be down to 1s and 2s. These are the symptoms that monitor child psychological abuse. These are the symptoms for child psychological abuse. You will see 1s and 2s on affection between the child and the targeted parent. The pathology will produce 1s and 2s on cooperation with the targeted parent and 1s and 2s on social involvement. And so that's the starting baseline phase that's anticipated. Then once we start to do our treatment interventions, we anticipate that all those ratings would rise up into the normal range. We don't need 6s and 7s. 6s and 7s are somewhat problematic, especially on the affection one. We want to see normal range affection. A 6 or a 7 for a prolonged period of time on affection would raise concerns about a role reversal, where it's the parent who wants to be loved and is eliciting these displays of over involved loving kind of situation. Now it's great if it pops up to, occasionally you get a day when it's 6 or 7 or a couple days and wow, my goodness, everything's wonderful. But we don't want it to stay up there necessarily. We want just normal range. Normal range cooperation too. Kid who's like cleaning their room on their own and mowing the lawn and doing everything without being asked is a wonderful child, but it's a little concerning because that's not a normal child, and we would wonder where that's coming from a little bit. And then social involvement would be sort of the same way. People have moods. Sometimes they get a little withdrawn, but then they come back out again. Sometimes they're very social, but they drop back down. If we have a child who's hiding away or very active and social, that's could be an indicator of a problem. So we want things in basically the 3, 4, 5 range. And you notice on the scale as well, I've put anchor points at the two extremes and then mostly kind of in the middle. And what the anchor points do is they improve the reliability of ratings so that we get more consistency in the ratings if we kind of give some sort of structure or guidance as to where the various anchor points are in the rating. And so the middle range, what's normal range affection? Well, kids open to affection, but they're not like crawling all over the parent and that sort of thing. But it's a nice relationship. Normal range cooperation, the child, you may have to ask them a couple times to empty the dishwasher, or to get your shoes on, we're leaving, and come on, I told you 10 minutes ago to put your shoes on. That's kind of normal range. But they cooperate. They're not like openly defiant, which would be a 1 or a 2. And then the social involvement. that they're participating with the family, and when you go out to dinner, they're social and they're normal kind of kids. They're not like all over you all the time. They play by themselves, play with their siblings or something, or watch TV, but neither are they hiding out in their room and just withdrawn. That might indicate some depression going on. That's why it's kind of a monitoring mood. Anxious, they might be overly social and that kind of thing. And so the parent every day would monitor these symptoms, and these are the symptoms that are going to be impacted by child psychological abuse. And so right now we anticipate them to be at ones and twos and then improve with the course of treatment. Now, when you propose to the treatment providers in the family courts that you're going to start with an outcome measure for them, or maybe they should have one, and you're going to rate the child and email the ratings to them because Dr. Childress recommended it, they're going to be terrified because their treatments are absolutely ineffective. And that's why we don't see any treatment outcome measures over here, because the treatment is zero effectiveness. The success rate over here is zero. And so the moment we start monitoring the symptoms, that's going to become obvious in the situation. And that has to do with the return of professional standards of practice. That if you're going to do treatment, you need to be successful at doing treatment, especially if you got child abuse and this type of pathology. We need to be fixing things. If you don't know how to fix things, then you need to leave. Find out how to fix things and then come back. Don't come into the family courts not knowing how to fix a relationship and then learn on the job or kind of take your best guess and stuff. No, excuse me, that's not how it works. Okay. Before you go work with ADHD, you need to know what ADHD is and what the treatment is for it. Before you go work with eating disorders, you need to know what eating disorders are and the treatment for that. If you don't know, then you get supervision or you get consultation and you get training in it. And that's what needs to happen for a lot of folks. I will be discussing elsewhere issues of competence in the family courts, but none of these current forensic psychologists are competent in the diagnostic assessment of delusional thought disorders or in the diagnosis and treatment of attachment pathology. And this is where it's going to show up on the attachment pathology. They cannot repair a breached attachment bond because they don't know how to do it. Plus, they're misdiagnosing what the pathology is. It's child abuse. And unless you can get a protective separation, no treatment's going to be effective. So let me talk about that for a second. Let me pull down the outcome measure here. There are 4 diagnoses of child abuse in the DSM-5. Physical abuse, sexual abuse, neglect, and psychological child abuse. Now, all of those diagnoses of child abuse are equally devastating to the child. Okay? They all destroy the child in some way. They differ only in the type of damage done, not in the extent of damage done. And psychological child abuse is absolutely devastating. It destroys the child from the inside out. And it's once we get locked in and the child has reached adulthood, the damage caused by psychological child abuse is pretty much unfixable. And they're going to be on a vastly different course in life than they would have been if they had had a normal range childhood. So psychological abuse is really devastating. And that typically comes from the narcissistic borderline dark personality parent. Those are the abuse pathologies. So we need to be effectively or successfully, accurately diagnosing the pathology we have in the family courts because it's child abuse, one way or the other. It could be the targeted parent abuse if we need to diagnose that and get that on a treatment plan. But if it's not the targeted parent, then we're looking at the child psychological abuse by a narcissistic borderline dark personality pathology. So when we bring treatment outcome measures back, the current crop of mental health professionals will scream bloody murder, and if you start to get, well, I don't do this or we don't do that, blah, 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 kind of stuff going on, that'll be a good indication to you that this is not a competent mental health person. Um, and so and then none of them are competent. So holy cow, it's going to be a little bit of a bumpy ride for a while. But we need to get treatment outcome measures over here because we need to get rid of the incompetent mental health professionals, and we need to get over here competent treatment. Now, one of the problems, there's only two reasons for treatment failure. And everybody in the family courts, all the forensic custody people, reunification therapists, there's no such thing. All those folks, there's only are unsuccessful in their treatment. The treatment success rate over here is 0. So there's only two possible reasons. One, they have misdiagnosed the pathology and they are treating cancer with insulin. Or two, they've accurately diagnosed the pathology, but they're not competent in the delivery of the intervention for that diagnosis. So, because if they've accurately diagnosed the pathology and they're competent in the delivery of the intervention for that diagnosis, then things will be fixed. And one of the reasons for the outcome measure is we want to see significant progress in about 6 weeks, 4 to 6 weeks. I'd like to see things moving in about 2 weeks. Something begin to come in 2 weeks, and then 6 weeks. I'd like to see significant movement on things. And now this is accepting what Dorsey Pruder has in the High Road workshop, which is 4-day recovery. I'm talking about my or the standard psychotherapeutic approach without that workshop augmented intervention. So from a therapy point of view, all the therapies that psychologists know and can do, dialectic behavior therapy, that sort of thing, I would want to see significant progress in about 4 to 6 weeks. Now, that's the psychology people over here currently aren't going to like that. But the reason that their treatment is unsuccessful is that they are misdiagnosing the pathology. Now, they may be incompetent as well, probably, but at the very least, they are misdiagnosing the pathology. And there's the 4 diagnoses of child abuse in the DSM-5. And to understand the severity of this pathology, we can just switch categories from psychological abuse to physical abuse. So if I'm treating a child who's being physically abused, beaten with electrical cords by his mother or something, and I'm trying to treat the child's acting out behavior resulting from the physical abuse of a parent, no treatment of mine will be successful as long as I send that kid home to the abusive parent to be beaten with electrical cords. Okay. If a child's being sexually abused by her stepdad, no treatment of mine for sex abuse is going to be effective as long as I send that kid home to be sexually abused by her stepdad. Okay. The very first thing we do with all forms of child abuse is we protect the child. So, and I know for a fact with severe attachment pathology, one parent or the other is abusing the child because that's the only thing that creates severe attachment pathology. And so either it's the targeted parent who's abusing the child, and that's a 2-person attribution of causality, in which case let's diagnose that and get it on a treatment plan, protect the child and get it on a treatment plan. Or if it's not the targeted parent, if that's a normal range parent, then it's the allied parent who's psychologically abusing the child of false attachment pathology and shared persecutory delusion. So it's going to be one way or the other because that's the only thing that creates severe attachment pathology. So I know it's child abuse. At the initial assessment, I just don't know which parent. And so we just do the differential diagnosis. We look at the various symptoms and we collect the symptom information, and that will tell us which parent is doing the situation. Now, the treatment for all forms of child abuse is standard of practice and professional duty to protect obligations is to protectively separate the child from the abusive parent. Now, I've worked with all 4 diagnoses of child abuse. I have led the treatment teams that have included CPS involvement on all 4 types of child abuse. And for physical abuse, I would probably say about a 6-month protective separation, and then we would look at parental risk factors, continuing parental risk factors, as to whether or not we would continue supervised visitation. Neglect, I'd put it probably a year, 6 months to a year, because I'm thinking of a meth addicted mom or an alcoholic dad or something where we have substance abuse that's leading to the neglect. Typically, we like about a year of sobriety, tested out sobriety, before we begin to move into a return of unsupervised visitation. For psychological child abuse, this type of child abuse, if you ask me what's my estimated time frame for necessary for protective separation, I would say, given my treatment sort of stuff, I would say about 3 months, about 12 weeks, because it's going to take me about 6 weeks to get a significant progress in there, get things back to normal range, and then I stabilize it for 6 weeks. So I would estimate around the 12-week period, we'd be able to reestablish contact with the formerly abusive parent. We always repair relationships, always, always, always. We might need to put on some supervision and protect the child from an abusive parent, but we always are seeking to fix the problem and restore a healthy attachment bond. So with that sort of context on the protective separation period and the diagnosis that's needed, let's move over to the next segment, and I'll talk about how we use an outcome measure like this during the protective separation period, and as the outcome measure extending out into the period of time when we restore contact with the abusive allied parent.